This is a discussion on shock. So essentially what's happening in shock is that the tissues are not getting enough blood. And with the blood, there's decreased oxygen. So decreased tissue perfusion, decreased O2. What happens is that the body goes from aerobic respiration to anaerobic respiration. Aerobic respiration, metabolism. Aerobic metabolism to anaerobic metabolism. One that has air versus one that does not have air. Your body can't last very long on anaerobic metabolism. So you rapidly run out of ATP. Also, inflammatory mediators are released. When you completely run out of ATP, the shock becomes irreversible. The best way to measure shock is by measuring the mean arterial pressure. The mean arterial pressure is pretty easily understood when you know that diastole is what's occurring in your body 2/3 of the time, and systole is only occurring 1/3 of the time. So diastole lasts 2 times longer than systole. So 2/3 part diastole, 1/3 part systole. So what you do is you take your systolic blood pressure. Well, I'll start with diastolic blood pressure. So you take your diastolic blood pressure, you multiply that times 2, and then you multiply that number, diastolic blood pressure times 2, you add that to the systolic blood pressure, and then you divide the whole thing by 3, and that'll give you your mean arterial pressure. So 2 times diastolic pressure plus systolic pressure, whole thing divided by 3, you get your answer. This is actually, I mentioned earlier, this is a better indicator of perfusion than systolic blood pressure because 2/3 of the cardiac cycle is spent in diastole. You got to also recognize, normal mean arterial pressure is somewhere between 70 to 110. If the mean arterial pressure is below 60, then this person is going to, there's not going to be enough blood pressure to get blood to their head and their kidneys, and they're going to die. So it has to be above 60, hopefully somewhere between 70 and 110. Another important thing to recognize with this is that the mean arterial pressure is also calculated by taking cardiac output and of mean arterial pressure that looks like it's okay because they have really low cardiac output, but really high stroke systemic vascular resistance, which would be the case in like cardiogenic shock. And if that's occurring, then the person would have a normal mean arterial pressure, but they'd still be in shock. So you need to be aware of that. If you want to check to see if their systemic vascular resistance is high or low, you can feel their hands. Now think about this. The systemic vascular resistance is determined by your arterioles, and their hands, they're going to be cold, clammy hands, whereas a person with lower systemic vascular resistance would have warmer hands. So you're going to determine peripheral resistance by the diameters of the arterioles. The diameters of the arterioles is what's going to determine the smallest vessels in the arterial blood supply. They're the main determinants of your peripheral resistance because they make most of the place where the blood is. And if they narrow down really tight, then your peripheral resistance is going to be really high. Now we're going to talk about some specific kinds of shock. We're not going to cover all of them in this lecture, but some of them. First of all, hypovolemic shock. This is extremely self-explanatory. Hypo, low, volemic, volume. Low volume shock. What's occurring? You don't have enough blood, okay? So your heart's pumping fine, everything's fine. You don't have, super high systemic vascular resistance or anything, but you just don't have enough blood to get everywhere it needs to go. And so with that, you're going to have the decreased tissue perfusion, decreased oxygen. So your body starts going from aerobic metabolism to anaerobic metabolism, and you're going to die unless you can increase this. So what causes hypovolemic shock? Well, sometimes it can be, from a hemorrhage or something. They're bleeding somewhere. a trauma or something like that. But sometimes it can be from something like just severe dehydration, or like diarrhea or vomiting or something like that. They just lost a lot of fluids. How are you going to treat it? Well, you need to increase the volume. You need to give them some fresh frozen plasma. You need to give them maybe a central line or an IV. Central line is useful, particularly because you can actually use the central line to also monitor. For example, if the centimeters of HTO are less than 15, then you need to really aggressively push in the fluids. Through the central line or IV, you can, it's very common, you'll give them 45 liters of saline and 6 to 10 packs of red blood cells, as well as a colloid. And that colloid is typically albumin, because sometimes they become deficient in albumin. You need to also watch their urine output and also listen to their lungs to make sure that everything's operating okay there. Next type of shock is compressive cardiogenic shock. And this is just anything that impedes the blood flow to the heart. Okay? So, for example, cardiac tamponade or tamponade or whatever the heck tamponade, whatever. Basically, blood around the heart. Blood around the heart is pushing on the heart, it's preventing the blood flow to the heart. This type of hypotension, when a person presents with this, you're going to see they have hypotension. You're going to look in their neck veins. You're going to see their neck veins are distended. And when you listen to their heart, it's going to be muffled, which makes sense because there's fluid around the heart. And so the sounds of the heart are going to be muffled. Also, you're going to find pulsus paradoxus. And also, the way that your diagnosis is by doing an echocardiogram. How are you going to treat it? Well, you're going to have to go into the pericardial window, open up a pericardial window, or you're going to have to stick a needle in there and get the pressure out. Next thing is going to be tension pneumothorax. So this is kind of a weird one. Essentially, my understanding is basically you get a bunch of air between the lung and the middle mediastinum, and all that air in there kind of like pushes everything off to the side, pushes it towards the contralateral lung, and the effect is that it decreases the venous return to the heart. Because remember, the blood's coming back to the heart, and you decrease that venous return, the person's gonna go into shock. Treatment is, again, you have to insert a needle or a tube to relieve the pneumothorax and get the air out of there. You also, sometimes they talk about doing a positive pressure ventilation, which I think is where you just breathe out really, really hard, and then maybe that can kind of get it out. But yeah. Lastly, neurogenic shock. Neurogenic shock is sorry, this actually isn't lastly. This is where the person has a loss of sympathetic stimulation from the high cervical cord injury. So in other words, they got an injury somewhere up high in their cervical cord, and now they're not getting any sympathetic stimulation to their heart or whatever. And this can happen sometimes from a massive head injury or inadvertent migration of spinal anesthesia. So you give them somebody's spinal anesthesia and it just kind of goes up there to spinal cord. There is arteriolar dilation and massive venous pooling of blood that results in hypotension. Fluid resuscitation can be started, and once hemorrhage is ruled out, either norepinephrine or phenylephrine will need to maintain the blood pressure. So norepinephrine or phenylephrine. You need it. Their brain isn't giving them enough alpha-1, alpha-2. I guess with phenylephrine it would be mostly alpha-1. Norepinephrine would be alpha-1, alpha-2, and beta-1 stimulation to really get the pressure high enough. The last one here is hypoadrenal shock. And there are a number of causes for hypoadrenalism, and I'm not going to worry about that right now, but basically what you do is you do IV administration of hydrocortisone. And that's it.